podcast. It is Clinical Tuesday, my favorite day of the week. I am Dr. Lindsay Huey, lead faculty for extremity management, along with Dr. Mark Gallant and Dr. Eric Chaconas. Today, I'm going to be chatting with you about FAI and squatting. Before we dive into the topic at hand, I do want to let you know some courses that Marky and I have coming up. This weekend, I will be going to Windsor, Colorado out of CrossFit Indoor, and we still have some spots left. If you'd like to join me, I would love it. It's always nice to have those mountain backdrops. And then November 12th, 13th, Ames, Iowa, you can catch Mark. And there's one final opportunity in 2022, which is November 19th, 20th in Candler, North Carolina. So that's that last shot to join us. But know that early in January 2023, we have four opportunities for you to come see our course. So January 14th and 15th will be in Philadelphia at Onward Philly. That will be a blast. And then January 14th, 15th will also be in Maplewood, Minnesota. So a couple East Coast options for you. And then the 21st will be in Maryville, Ohio. And then the 28th I'll be in St. Augustine in Florida. So if you want some warm weather in those colder months, would love to see you. All right. Thanks for letting me share a little bit about extremity management, what we have coming up. We'd love to see you. So, FAI and squatting. Squatting is one of those number one complaints of the person with femoral acetabular impingement. We see limitations not only like in sport participation, but just in daily life, right? We have to get on and off the toilet, in and out of our car, on and off a couch, on and off a chair. Squatting tends to be a part of all of those activities, right? So this is a place we really need to know how to intervene for our patients and get them back to squatting. As Catalelli et al. And team from Frontiers in Sport and Active Living Open Access Journal in September 2021 kind of sought out why are these humans having pain with squatting? Because we see people with FAI that have pain symptoms with squatting, but we also see people with evidence of FAI that don't have any pain in their squat. And so they really wanted to undertake the question, why is it in some that they're having pain? So what they did is they took a group of 39 male individuals and they split them into three groups. 13 of these individuals had no signs of femoral acetabular impingement or CAM impingement, as evidenced by X-ray and special tests, Faber and Fader. 13 of these humans had CAM FAI and pain associated with squatting, positive Faber, Fader, and findings on X-ray and CT scan. And then these other folks had no pain with squatting, but evidence of CAM FAI, again on X-ray, CT, no symptoms with Faber and Fader. So what Catelli et al. And team did is they specifically were looking at muscle force generation in the deep squat of these folks, and then what are hip bony contact forces looking like in the three various groups. So again, just to review, asymptomatic individuals 13, symptomatic with FAI, and then asymptomatic with FAI. So they looked at, they mapped out joint trajectories and ground reaction forces by putting markers at the pelvis. So they looked at pelvic tilt. They looked at both hip sagittal angle, so hip flexion motion, hip frontal angle motion as well. And then they looked at muscle force activation produced by adductor magnus, biceps femoris, gluteus maximus, psoas, and rectus femoris and semimembranosus. So they wanted to determine, were there variations between these three groups? And they specifically captured that analysis via 5 deep squatting trials. So they had all individuals perform a deep squat at their own self-selected pace. Ideally, they had hips at hip parallel of the individual and feet position at parallel. And then their arms were stretched out anteriorly. So everyone was tested in that way. And so what they found was that the asymptomatic folks with FAI, so no symptoms, but having evidence of FAI, showed increased pelvic tilting. and increased hip flexion angles compared to the symptomatic FAI group. And this was also consistent in the control group, where that increased pelvic tilt is present and increased hip flexion. So, saying that conversely, symptomatic folks with FAI were in a more posterior pelvic tilt position in their squat. In regards to muscle forces, what they found was there was greater forces in the asymptomatic individuals and control groups in some muscular pairing, specifically for psoas and semimembranosus. In the folks that had the 13 individuals that had symptomatic FAI, biceps femoris was greater in this group. And they had lower activation or muscle recruitment in the psoas and semimembranosus muscles. They also looked at bony contact of that femoral neck in relation to the acetabulum. And in both the asymptomatic FAI folks and control group, so no signs of FAI, they demonstrated significantly higher posterior hip contact forces compared to the symptomatic FAI group. The FAI group just had lower posterior contact forces compared to the control and that symptomatic group. So what the article suggested, that this movement strategy of the person with FAI, it's like they're trying to avoid or unable to produce that posterior contact force. I know I just gave you a whole lot. It's a big summary of kind of what they found. I'd love to unpack just a little bit about what that probably means to our care and what we should be thinking about when we are treating humans with FAI and how we can get them squatting pain-free. So in summary, biomechanics and muscle forces are different in symptomatic individuals with FAI compared to their asymptomatic counterparts, and then just a control group, people that don't have any evidence of FAI. The article suggested that possibly this difference in muscle activity of psoas and semimembranosus may be a protective sensory motor strategy to avoid pain or avoid bony contact, so that a symptomatic person with FAI adopts a more posteriorly tilted pelvis. And we've seen that in past literature as well, that's a really common finding when the human with FAI is squatting. At the mid phase of the squat, during its lowest step, there is a posterior tilt to the pelvis, and that is reached in normal individuals due to glute max firing and then hamstrings. So this is actually disrupted then in the person with symptomatic FAI because that's not happening as readily. So the semimembranosus, in theory, just a little reminder of biomechanics, should act synergistically with the glute max to support that posterior pelvic tilt. But again, in symptomatic individuals, this isn't happening. So this imbalance in muscle force production, whether it's compensatory, whether it's weakness, whether it's a guarding mechanism, we don't actually know. And this article can only make conjectures, right? And now we, as the consumers of that literature, can only make conjectures as well. And so I want to suggest what we think is best practice based on this evidence, what we've known in the past, and then just what exercises fire up muscles around the lumbopelvic complex and hip best. And so here's the best way that we know right now to manage those with FAI that we need to get squatting. And that is, first, only always, will reduce pain and irritability. And so for the person initially with FAI, especially with higher irritability, they often have some initial range of motion issues on board or joint limitations. So we definitely go after this first. So in extremity management, we put the person with FAI in the intra-articular hip bucket initially. But this article suggests and confirms that someone with FAI ultimately belongs in our extra-articular hip bucket as well. We need to pay attention to those surrounding soft tissues, right? And how they interact with the pelvis and pelvic movement as we squat. And so specifically, I take this 2021 article as really a call to action to go after that iliopsoas and semimembranosus earlier. And it's not just about a tighter iliopsoas, right? We think about that causing stressors to that anterior capsulabral complex, which we, from when we have our biomechanical hats on, we believe that that's causing decrease increasing bony forces and then bony degradation and pain. But this article really suggests that that might not really be the case, that it's more altered, right, muscle function. And really, that iliopsoas, maybe it's initially masking as some tightness, but it's really weak. And there's a lack of coordination between those muscles. So we're going to not only address range of motion restrictions early on, but we're going to address irritability of the surrounding soft tissues. And iliopsoas and semimenosis specifically, we're going to treat with myofascial decompression, dry needling, and soft tissue techniques, right, to get that tissue irritability down and pain down. We also need to make sure there is pelvic mobility freedom, right? If the human with FAI is unable to get into that anterior pelvic tilt throughout their squat and move into posterior hip tilt, they're not going to move well. So we really have to make sure that's restored, and that there's freedom there, and that they're not stuck in one position or the other. And as they squat, they're able to move in and out of that. Other intangibles that we really have to address early on in the person with FAI, right? That's probably unable to do their sport, and some things that are important to them in their life is that we have to reframe their mindset, right? Their inability to participate in things that are important to them. Finding a way to keep them active, even if it's not in their sport, is really key, right? We don't want this human just sitting on their booty. We want to keep them active. So that's, number one. And then addressing ecosystem considerations, right? Like the things while you're working on getting tissue stronger, which we know takes a little time, and working on restoration mobility, addressing holistic ecosystem considerations like sleep, diet, what's your fuel like? Are you eating enough protein? How's your hydration? And then just overall stress management techniques, especially if you are treating an athlete that's kind of pushing through the pain. We're going to treat local tissues, right? Which won't surprise you. Specifically, we are going to go after anterior, lateral, and posterior structures. Anterior, when we think about after tissue irritability is down, how do we load this human up? Well, we're going to start with a psoas march, right? And then we're going to eventually lead to an eccentric kettlebell lowering, right? We can't necessarily start right at that kettlebell lowering if there's high irritability on board, but that's our trajectory to get to that place. For that lateral hip, lateral chain, we're really going to go after initially some clamshells, but that's just in the early stages. And then we're going to eventually move to a sideline hip abductor plank with a leg raise, because that has been shown to really produce that glute med activation the best. And then from a posterior chain perspective, right, going after glutes and hamstrings, specifically that membranosus, we're going to maybe initially start with a glute bridge, right? But let's get them moving to a barbell hip thruster. And so that's kind of when we're working towards end stage resilience of the surrounding tissues, we're going to do all three of those. And then eventually working on those adductors as well. But special focus will be on those anterior, posterior, and lateral tissues. And I want you to know, if you haven't been to an extremity management course, when we're going after local tissues, so initially in those anterior, lateral, posterior phases, we're really going to go after what's called the rehab dose. And we call that dose that addresses dysfunctional tissue issues, tissues that are pain dominant. And so we'll work anywhere from 8 to 20 reps at a 30 to 80% intensity. So an intensity that respects irritability, 3 to 4 sets with a 90-second break. And as irritability dampens, then we continue to increase intensity. When we're thinking about global musculature, right, we want to work the whole chain. We want to get loaded up squats and loaded deadlifts. We want a strength dose. So we need to challenge those tissues at a 5 reps, 5 sets, greater than 80% 1 rep max. And we're working so intensely that they need a 3-minute break. That really, team, is in a nutshell how we will treat FAI well, right? We will address any irritability in local tissues, then we start loading them up with rehab dose. And as that dampens, then we want to get multi-segmental joint function like the squat and the deadlift, loading that human up more and more. This article, somehow I missed reading it up until now. It came out in September 2021, but it really made me take a pause again and just really want to implore everyone that treats those with FAI to consider the underlying pathoanatomic anatomical structures less here, right? What this article really suggests is it's more a muscular coordination imbalance, not a bony contact issue, right? We have people with the same amount of FAI on board squatting pain free. So it's something else. And we really have to address those soft tissues well in the early stages with higher ability and then really get them loaded up. So we need to stop biomechanizing our humans in an unhelpful way, promote confidence and squat freedom, get that pelvis moving, get those local tissues more resilient, and then global musculature um, functionally resilient and dominant, right? Get them so strong that their tissues are no longer vulnerable. Help your humans with FAI get their squat on, right? Build up the human first, only always, and then their tissues. It's always and not or. Thanks for sharing your Morning Tuesday with me, all team. Happy, happy Clinical Tuesday.